So I was really excited when Christopher Wasden, who's the managing director at PwC, agreed to come and moderate this very important discussion. So back to my mottos. His motto, creative tension powers innovation. I'll let you guys take it from there.
All right. We've actually got a lot of great perspectives for this discussion today. We've got an entrepreneur that's got a health services company that's providing wellness solutions, and he's a physician as well. You don't get that combination very often with Samir. So that's a great perspective we'll bring to this discussion. We've got the perspective of a large health plan and what they think of prevention with Richard, so that will be great. And then we've got a technology company, and they can talk about the role that new technologies are playing in that. But before we get started in the discussion around health and policy, I wanted to talk about 5 myths that I want the panel here to try to debunk as part of our mission today as we talk about prevention as policy. And the 5 myths are myths that really get in the way of us creating prevention as policy. So the first myth, and I've got them here written down so you don't have to write them down and remember them. I'll kind of bring them up as we go. But the first myth is that prevention in all its forms, including wellness, doesn't pay. So when you look at the studies that have been done on wellness programs, for example, every single study says that wellness programs do not decrease medical costs. And so I think the panel needs to talk about whether or not wellness and prevention pays. And in the traditional sense of prevention, when we look at these screening types of tests that have oftentimes been done as a form of prevention, we don't see really attractive medical ROIs on that. And then we also find that because of the lack of medical return in prevention programs, we've begun to really focus on other things like productivity, presenteeism, absenteeism. And increasingly at PwC, what we're focusing on is actually happiness. Does prevention create happiness among employees? With the view that if an employee is happy, maybe then they'll be more productive, then maybe they'll be healthier, and then maybe you'll have decreased healthcare costs. So that's the first myth. The second myth is that prevention doesn't decrease incidence of disease in areas where it's applied. So there was a recent study that came out, I think it was last month or the month before, that looked at all these different preventative programs that we have in the United States. And what we found is that the U.S. spends more on prevention than all the European countries, significantly more, but yet we don't have better outcomes from health. One of the examples they gave is in cervical cancer. We do 5 times more screening per capita of cervical cancer than any country in Europe, yet our outcomes from cervical cancer are worse than every country in Europe. So how can we spend 5 times more on prevention and get worse outcomes in an area? And they used that as just one example. They said the same is true in prostate and other areas. So prevention doesn't decrease incidence of medical or of disease. The third myth is there's no scientific evidence of its efficacy. Doctors go to school to study science, physics, biology, chemistry, statistics. So doctors consider themselves scientists. And as scientists, they want to apply the scientific method to things and only apply and practice medicine that really measures up to the rigors of the scientific method. So when we look at a lot of the research that's been done on wellness programs, prevention programs, mHealth is an example as well, which is a new area. What they find is the research doesn't suggest that it's actually effective. And so doctors say, well, why should we even focus on this if it's not effective? And what we find, and this is why Johns Hopkins has jumped into the fray here, is that a lot of the evidence is focused on the newer wellness programs that are on the mHealth digital health front really don't look at the new technologies because they're looking at research that occurred before the iPhone was even invented. And so we need to think differently about research and also the fast change of pace. For example, with a Qardio technology or with what Dr. Damani's focused on, we're not going to have 10 years of research. We're not going to have 5 years of double-blinded clinical trials to test whether or not this is good. So how can we deal with efficacy in this sort of a world of rapidly changing technologies? The fourth myth is that doctors don't want the data that are generated by patients, and they don't trust data generated by patients. And what's interesting about this is that of the 262,000 minutes that we live every year, we spend 60 of those minutes with a doctor. And during those 60 minutes, the doctor gathers a few biometric information about us, but not a whole lot. And so most of our healthy behaviors and activities do not occur in a clinical environment and are not recorded by a doctor. So we're the ones that really are generating most of the data about us, most of the health-related information, most of the prevention-related information. So how can we get doctors to start to use and to trust this information? Because right now they feel overwhelmed by the information and they don't trust information that we generate as consumers. And the last myth is that technology won't help doctors. Where doctors have failed to get us to change behaviors, they don't see that technology is going to make a difference. Now, I would argue that a lot of the problems we have in health are the result of technology. Technology has been really good at changing our behavior to be couch potatoes, okay? It's been very good at changing our behavior to eat things we shouldn't eat. So if technology has been so good at changing our behaviors for the bad, why can't technology be part of the solution to change our behaviors for the good? So how can we use technologies to really change behaviors where doctors have failed to change our behaviors? So those are the 5 myths that I want us to work on debunking during the next 40 minutes or so. So Samir, you want to do a bit of an introduction, and then we'll start talking about some of these things, and we'll get to Qardio's video as well?
Sure. Do we have perfect?
There you go.
Well, Chris, as a practicing cardiologist, I would say about 5 years ago, I would subscribe to the notion that I didn't think wellness worked, or that technology in the prevention setting was really ready for prime time. But it was in 2011 when I started seeing that people were purchasing, some of my patients were purchasing these devices like the Withings blood pressure cuff and using this app to stream data to me, telling me that maybe they need to dose their medication in the morning versus the night because their blood pressure changes were diurnal, and they found out that they needed to really dose it at a specific time. I also noticed that certain patients who were, especially as you get in your 50s and 60s and 70s, we become more sedentary, a lot of my patients, and so a lot of them started equating physical activity with exercise. So they would think that working in their backyard and their garden was actually exercise. You get them a heart rate monitor, and all of a sudden now they stream that data to you, and you can show them that, wait a minute, you're not exercising. Your heart rate really never got above 100 beats per minute. We also see, although 23andMe is going through some regulatory issues now, we saw 400,000 people order genetic testing with 23andMe just this year. And that's going to come, that's going to continue. It shows that people are interested in their biology and what it means to them. And these are people, this wasn't prescribed by a doctor, they were doing it on their own. We have scales which now measure body fat, which is a much better indicator than weight and BMI in terms of predicting the onset of obesity. And even some of the things like cancers, like prostate, breast, lung, are all preventable conditions and driven by things like visceral fat, body fat, as well as low fitness levels. So what I saw is that there's an actual science to this, but that the industry hadn't recognized it because industry was brought up by the consumer electronics industry. And so what we did in 2012 is we created a lab because I felt like there needed to be some scientific rigor brought to how to use these devices. And so here you can see our clinical lab. We have a mobile health bar right there where people learn how to use these devices. And it's not actually about the physician. It's about everyone but the physician. It's really about giving control back to the patient and letting them talk to basic IT people to learn how to use the apps, helping them curate out of the 40,000 apps that are out there, curate the ones and let them know which ones might be most effective for them. And then what we found was that outcomes were actually tremendous. We started seeing, in 112 patients, we're preparing this for publication now, 112 consecutive patients, we saw that about 70% of them were not only improving in one category of weight, but they're improving in 3 different categories. VO2, so V is volume or consumption, O2 is oxygen, ability to consume oxygen, which is probably the most powerful predictor of death we know today, yet we don't use it because in our disease-centric fee-for-service system, we want to prescribe a statin. We found that these people were improving in that parameter, and then visceral fat and body fat. So we're seeing that there's a tremendous engagement that happens with this, and you just need to build the right system to scale it and to manage populations. And so to do that, we built RevUp Health Accelerated, which was a software platform, which is a patient engagement platform where I realized that what we needed to do in order to start using these tools in massive populations, that we needed to start assigning points for the things that are important to people. So if they did exercise beyond a certain heart rate, they would get a certain amount of points. Or if they just stepped on a scale, they would get a point. Or if they measured their blood pressure. And so we now have an enterprise solution where we're delivering our solution to large health systems, and we're seeing dramatic results in the same setting, and we're able to track points. So we're able to see when a population points are dropping, we know they're not doing what they need to do. We can message them, and then the person, the patient, the consumer can see all their data. So we started out as an enterprise solution, and now we're releasing this consumer product, actually, where the coaching is going to be free for a limited time. You can get on the platform and try it out. It's to really enhance our platform to see how the product will fare in the market at large. And so I really think there is rigorous scientific evidence now that there is something real with wellness. As far as the second point that you made regarding the cost effectiveness, I think, I was having dinner with an investment banker last night who said, anyone that says that prevention doesn't pay, ask an investment banker what it takes to replace their top banker who died from a heart attack. And they'll tell you that, what prevention does pay, because 80% of heart disease is preventable. So I'll leave it at that.
So Richard, Dr. Damani here addressed some of these myths and tried to debunk them. How about from your perspective as a big health plan? Do you guys believe in prevention? Do you invest in prevention? Do you think technology is part of the solution? What are your views?
We do believe in prevention. And one of the things that gets confused is measuring the effectiveness of prevention programs rather than measuring their efficacy. It's just like a pill. Let's say efficacy is if you were to do something, does it work? I think there's really no doubt that some of these prevention capabilities, whether it is trying to stay well and manage your metabolic factors down, like you see in the Framingham study, or if you already have existing disease, managing and preventing the progression of the disease by staying on track with good evidence-based medicine. That stuff works. It works in a laboratory. The issue that gets confused is when you go out to society with those kinds of applications, can you get people to engage? So when you see a failure to see impact, you've got to start recognizing, do we have a problem with efficacy? In other words, does the intervention work? And my argument is, yes, it does work for the very things that Samir was just pointing out. The second thing is, can you get people to use the damn thing? And that's the effectiveness. And I think that's what CES is all about. Finding ways to be making prevention part of people's lifestyle. We all have the monitors. I got 4 computers with me today. I don't know why, it's just habit. I just feel safe. But when you have that kind of capability, why not bring prevention to that platform? And I think that's the kind of wonderful things that both of these gentlemen are talking about and what you're seeing out on the floor. So before we poo-poo prevention, let's make sure we're not talking about the scientific elements of efficacy, which does work, versus that of effectiveness, getting people to use the damn thing.
So let's switch to Marco then, and you've got a video to share with us, but I'd like specifically for you to talk about using the darn stuff, right, and making it useful in your life and what your experience has been.
Absolutely. This is what Qardio is all about, and this is how we defined really our mission. So we wanted to develop medical devices that are actually easy to use, so people can regularly look after their own health, and make it easy also for their close family and close friends to be supportive in monitoring regularly people's health. So picking back on the point you were mentioning before about the iPhone, before 2007, you used your phone just for phone calls and maybe emails, right? And now you can use it for managing your stock portfolio. You can manage it for your recipes. You can manage all your personal notes and work notes on it. You can even play PowerPoint presentation on it. One thing that is still kind of hard to do with these devices is actually tracking your health. And that's what we're changing with Qardio's products. So we have products that are designed not even to look and feel like medical devices, so that you can have them around you all the times, so they can be within arm's reach and accessible, and really facilitate people in feeling comfortable with having these devices to measure their blood pressure or track their heart health regularly, right? So to explain better what I'm talking about, I'm going to play a small video. So if we can go back to the presentation.
Marco, the flash drive that you gave to us does not have a video on it.
I'm pretty sure it does. I can give it back to you.
Alternatively, Marco, we could have you
We could have live
do
action.
it on live on stage. You can actually demo it yourself.
I can demo, I can definitely demo the blood pressure monitor and the ECG
Sorry.
as well. But there is a video
We
there.
had 3 experts working back here feverishly looking for it.
So while they're feverishly working, let's chat a bit about actually getting people to use this stuff. So, Samir, I know that you've used these technologies with people that range from very old to young to having obesity as a real problem versus people that are actually triathletes that are just trying to improve their performance. So what has been your experience in getting people to actually use all these different devices and do it on a sustainable basis?
The biggest challenge is, first of all, you got to establish, anytime from the laws of diffusion innovation, you want to establish who your target is, not from a demographic in terms of disease or not disease, young or old, but in terms of who is able and interested in the technology. So,
Okay.
I think number one is finding out who has a smartphone.
You ready to go?
We're good to go.
All right.
Okay.
So we'll come back to that. Go ahead, Marco.
Okay, so if we can. Perfect. This is our cardio arm, our blood pressure monitor. You can have it in your living room. It would be really hard to even spot that you're left on the coffee table, or you can have it in your pocket. You can travel with it anywhere. You go on the coffee table in the living room. It's something really you can have around your life, and to help you measure your blood pressure, blood pressure anywhere, anytime. This is Qardio 4, our ECG monitor. Tracks ECG, tracks physical activity, body temperature, and galvanic skin response. And we have a proprietary sensor technology that requires no skin preparation, so we get rid of patches, wires, and gels for our ECG. This is a presentation of ECG. Okay. So, going back to the points we were mentioning earlier, by having devices like these that don't even look like medical devices, we really facilitate people in having them all the time. And we put the information available at their fingertips, in their mobile phones, on their tablets, so it's easy for everybody. And the doctor, the information is wirelessly synced between the devices and the smartphone, and then from there to our cloud, and we make it available directly in the hands of the doctors or the health providers.
Mm-hmm. So how important is the doctor in this whole chain of distribution of technology and in getting engagement? And one of the things that I find interesting is the Fitbit device was never, as far as I know anyway, was never promoted as a medical device for doctors to prescribe to patients. Yet, because consumers adopted it, Mayo Clinic uses it in clinical trials, other sort of health plans are beginning to pay for it and tying health benefits to it. So you have the health community engaging it only after consumers already adopted it. So should we be focused just on the consumers and getting them to adopt all these new technologies, or should we be relying upon the physician to play a role in that? So let me start with you, and then we'll end with the physician.
Well, I would say that the physicians definitely play a role. They are a crucial actor in this, and they definitely need to be engaged into these changes that technology is bringing upon us. There are lots of advantages which, with our system, we can provide to physicians. We can really enable them to focus on their time on taking care of patients that really need attention, and all the routine checkups can happen, dedicating just a few minutes every day for hundreds, even maybe thousands of patients at once. So,
But doctors like the ugly stuff, right? I mean, they use the ugly stuff for decades. They never asked for nice, cool stuff. They never cared if consumers or patients wanted cool medical toys.
absolutely, but I think the point is not about creating cool medical toys. It's about creating devices that are cool, easy to use, and also bring an actual advantage in terms of increasing the efficiency, increasing the ability of the health provisioning platform to be more scalable. So you need, with the same number of doctors, you can cover more people, you can cover those people better.
So what's your view, Richard?
The docs are core to this to make it to work because they validate it. You do have to be consumer-centric because they're the ones that have to use it. Because just like Samir had said earlier, 50% of preventable, 50% of premature death is caused by self-inflicted behaviors. All right, so it's changing a behavior to get it. In order to make it, I just took this off my belt, it's a Fitbit. Why? Because we've learned that the only way you're really going to say that you're actually making progress to a goal is by having something that documents it. And when you have something that documents it, it changes a consumer's behavior. It's changed mine, it's changed the other. You can take a look at the picture that you got there. If you look at the role of the physician, though, it's one of the things that we found that's vitally important, is that the physician many times is necessary for the prevention. They help you assess the risk. And when people think about prevention, somehow they just wire it up to it's only the healthy people without disease. Prevention involves everybody. So it's also keeping track of people with already firmly established disease, and you're going to try to prevent its progression. So in order to get that to start happening, your physician's got to be aware of the things that they're missing. Give you a case in point. 1 out of 5 people handed a new prescription for a statin never fill it. And 50% of those who fill it stop taking it in 6 months. The physician has no idea that you've stopped taking it. In fact, it's usually the patient comes back and misrepresents both whatever they're trying to measure, blood pressure, whatever, as well as misrepresents that they're taking their meds. Well, the doc raises the dose because he's not seeing the effect, he or she is not seeing the effect. They raise the dose, the patient comes back, still no effect, we raise the dose, we go to a stronger agent. By the time the patient feels guilty and takes that new med, then all of a sudden they're on their backside because they got a drug that's clearly overprescribed, and it was just their lack of effectiveness, their lack of engagement. So to keep prevention moving forward, both parties have to be informed, the individual as well as the physician. To prove that, though, and we have such faith in it, that if you look at the way in which we structure our benefits, we're putting incentives in to cause people to want to participate as consumers. At the same time, using the same factors that we look at, the same outcomes and behaviors, we're also paying the physicians differently on risk gain programs and the like. Fully 26% of what we spend now is in contracts to physicians that pay them for doing a better job. Well, a better job means getting both patient and physician aware of the gap and then taking them to take action.
So what incentives are you providing me as a consumer?
All right, so we started with our own about 4 years ago when we started seeing with our own 160,000 employees adverse trends. So what we said is for every adult, you had to give us 4 numbers, your blood pressure, your body mass index, your LDL cholesterol, as well as your fasting blood sugar. Any one of those 4 things were wrong, you had to enroll in a program. If you did the testing and enrolled in any relevant program, you got $450 subsidy towards the next year's benefit plan. All right?
Okay.
Now it's up to $600. And the reason it went up to $600 is because we wanted even more. That very first year, the things that happened is, number one, is that 75% of people participated. 26% of people got all the points, and 50% of people got some money for getting half points. What was amazing is what we found. We found that we had 7,007 diabetics out of 88,000 adults. 7,007 diabetics. 443 of them didn't even know they have it. So a good part of prevention is just know where the heck you are to begin with. We had a 600% increase in people enrolling in weight loss programs. 45% of them lost at least 9 pounds. What happened with that? Within the first year, we had a 19.6% reduction in costs for diabetic complication care. We had a 12.3% reduction in cardiovascular-related costs, 10 fewer of us, or about 12% fewer heart attacks in the population. So when you start looking at that kind of participation, you start recognizing that it has an impact. Oh, by the way, our trend, which was 9, dropped to 4, and it's been 0 for the last 2 years in terms of our expenditures. The stuff works, but that's why you got to be able to look at it as a system, and it's not only doing the right thing, but giving reinforcing capabilities to both patients as well as physicians to do the stuff. The mobile technologies that you see are enablers to get that stuff done.
So Samir, from your perspective, there's the Qardio devices, there's the WeThings devices. How do you as a physician make a decision about which of these devices you want your patients to use? And then what can you do about incentives? The health plans have these buckets of money, at least we envision you have buckets of money somewhere, but that you can kind of dole out to people. Employers have that as well. But what can you as a doctor do to provide incentives to patients? Because you don't have money, do you?
Well, so first of all, I think we need to get this concept that the doctor is going to cause all of us to be healthy. It's just not going to happen. I mean,
you're a pretty powerful guy, though.
Well, you know, I can see 15, maybe 20 patients a day as a cardiologist. Right. And I have 10 minutes, and that would, just to even show people how to use these devices, it wouldn't work. So I think there's going to be a physician shortage of 90,000 by 2020, the American Association of Medical Colleges said. So I think first and foremost, we have to get rid of that. Now, the good news is that the CDC says 80% of heart disease and 40% of cancers are preventable. So when you look at what cancers, you're talking about prostate, lung, breast, colon. Why? If you look at visceral fat, body fat, VO2, they all correlate not just with heart disease, they actually correlate strongly with these cancers. Mm-hmm. So you start looking at what measures do you need to move. Well, guess what? These measures don't require a pill. They don't require a doctor. They actually require a little bit more precision with the way you live your life, whether it's seeing how active you are or inactive you are, whether it's wearing a heart rate monitor to get high-intensity interval training in, which is a new science that's emerging with how effective you can be in short periods of time, whether it's just logging your meals to actually be more aware. So I think that what we really have to say is that we're dealing with conditions that affect that impact 1 out of every 2 deaths are from heart disease and cancer. While at 1900, it affected 1 in 10. So you went from communicable diseases to non-communicable diseases. So you're not going to solve a behavior disease with a pill. So it doesn't need doctors. It doesn't, okay? Now,
so this is an important point.
Okay. But
what we're talking about doesn't need doctors. So
but here's what it needs. It needs doctors to support the effort. Okay. We have to support and be knowledgeable, at least when your consumer comes to you with these devices, because that's what happens, and know how to use it. And there's 3 things that have to happen in order for behavior change to happen. There has to be financial incentives that are aligned. There needs to be the social piece, and there needs to be the physical piece. Mm-hmm. So the financial incentives are finally aligning. Okay. Healthcare reform now is making consumers pay more for healthcare. We all probably are experiencing higher copays, higher deductibles, which is good. Mm-hmm. We need to realize prevention is going to be cheaper than treating disease. Right now, treating disease is cheaper than preventing. Mm-hmm. That's number 1. To the consumer it is. To the consumer it is. Right. So that's changing. All right. Number 2, the physical piece. You know, we moved from an analog world where prevention was health risk questionnaires and getting touches to fill in a nutrition log once a quarter, and out to a digital world where it's 24/7. Mm-hmm. Prevention is not 60 minutes in a doctor's office, it's 24/7. Mm-hmm. So we have to teach lifestyle, and there's not enough doctors to teach that. So we have to have systems to do it.
Do doctors know lifestyle to teach?
Well, I think again, we're missing the point. It's about systems that need to be built that can educate people based on data that's being brought in by these devices and then sending information out to masses and tracking people and making them accountable. So who's going to...
And are you as the doctor tracking these people or somebody else tracking these people?
Well, at MD Revolution, we're tracking large populations of the people.
But you as the doctor, I mean, are you getting a sheet for every patient every single day with all this data on it? Or?
We have a software platform that actually our nurses, our metabolic specialists, some graduates just with the exercise physiology degree are actually checking and coaching people on, just logging, just getting things done. And then, but the important thing too is that the physical piece is gone now, right? You no longer need a doctor in front of you to actually give you information, give you feedback on these tools. So what we really need are platforms that allow massive management of populations. And there's nothing out there like that. And that's what we've created RevUp, is the ability to aggregate and then have algorithms driving intelligent coaching, right? So if you have a population of 1 million on a platform and 100,000 of them put on 3 pounds of weight, and now you have somebody emailing those people and say, hey, we noticed you put on 3 pounds of weight. Can you consider this? To that person, even though you're sending out to 100,000 people, they know, oh my gosh, somebody just told me I put on 3 pounds of weight. Maybe I need to do this, and offering suggestions. Maybe you need to use your Fitbit more. So I think what I'm saying is that, it's the technology. All these technologies are important. It doesn't matter which one you use. Obviously, there's issues of some people, I like the Qardio because it's low profile, it's comfortable, it's convenient. Some people might like the Withings, but I think that's a preference issue, and I think there needs to be guidance on that. But at the end of the day, it's going to be the consumer who really engages with the platform. And on our side, on the healthcare delivery side, I think what we need to do is how do we take the data from these devices and make it meaningful to the population at large? Because right now, that's not happening. These are just cool gadgets that people are wearing, and everyone's doing their own thing with them, but there's no organization. And I think doctors are maestros of that process. They can orchestrate that process, but they are not going to be the ones individually who are actually out there making change one person at a time. And I think there's this concept, I think, in people's minds of saying doctors are going to be doing that. It's not possible. There's not enough bandwidth. So we need to build the platforms, and we would love to partner with the UnitedHealthcares of the world to actually say, all right, let's try pilots and studies in managing 1,000 high-risk patients and or 10,000 high-risk patients to see what happens. And you've already documented some really great benefits from that. So I think that it's a partnership and making prevention as a policy for employers and everybody else as part of your kind of ethos.
Now, Marco, Samir's talked a lot about platforms. And whenever we get into these technology discussions, the word platform comes up. How do you, as a technology company with some devices already available, others I'm sure in development, how do you approach the platform problem, and how does that help consumers become more engaged?
Well, the way we approach it is we have built our own platform to manage this data and to integrate this data and provide the information directly in the hands of the people that can extract best value out of it. So to the doctors and health providers, definitely. So it is, I guess one way I like to put it is, 30 years ago, 40 years ago, if you wanted to use a computer, you had to go to the main building of your university or the headquarters of your corporation to access one of these big mainframes. And then the personal revolution came, and computing became pervasive, available in every house, in every office, right? And right now there's still, the access to healthcare still works like computing was working 40 years ago. You have to go to the hospital to access most of these services, right? This is changing, can change, and with the connectivity, with the internet clouds, you can make this information available quickly, almost in real time, to the people that need that information, can make the best use of it.
When we look at prevention as policy, though, there's, I don't know, if there were 100 different blood pressure cuff companies coming up with new technologies, and doctors can't recommend 100 to all their patients. So how does all the data flow? How do you make it interoperable? Is your platform a closed platform? Is it an open platform? Do you have APIs that you enable people to have access to so that information can flow into the EHRs of the physician or to the records of the health plan?
Yeah. So, with our products and with our platforms, we have features and we do things that are not available with other products. So the cloud we have is actually designed to make those features available to doctors and to patients. So we decided not to make it limited by the limits that are that you find with other products. So in fact, the platform is designed to work with our products only, and to make it, however, very easy for doctors to manage this information and be able to monitor a large number of patients in a very small amount of time, so to make it very efficient and effective.
So Richard, let's switch to dealing with employers. So you provide services to employers. Are they on the bandwagon for prevention as policy? I mean, do they get it? Do they want it, or do you do a lot of hard selling and saying, look at the UnitedHealthcare data, it's very compelling, we've got years of experience, here's the economic benefits, you should do this too?
All right, let me give you a little bit of background on it. We serve some 250,000 different plan sponsors. For the most part, they're employers. If you look at that spectrum, they range from the one and twosie small shop to the mega shops that you see, the brands that you've had a lot of comfort in. And I know some of you in this room. And so it's good for me to be able to say this as well. Some of the most creative things that we have seen have come through our partnerships with some of these companies that are so good at understanding people. There's a retailer in this audience that I won't call out, but they're here and you'll know them because they got a dog with a red circle around their eye. They have some of the most sophisticated programs in getting people to do something preventive. And we learn from them. And then what we do is we learn to scale with them, because as Samir is saying, as well as Mark, you can't scale up a physician-centric capability. You have to be able to use information. So it starts with the campaigns. Not only are the employers, the real leaders in cutting edge, like I just mentioned, good at design, they're phenomenal at engagement because they get directly involved. They will rebrand some of the capabilities that we have so that it fits into their workspace, so that people as they go to work are reminded. And what it does is to lend to a phenomenal culture of wellness and health, because it gets to the point that you were reading with one of your other myths, the issue related to, does this stuff really translate? Does being healthier create a better workforce? Well, when the U.S. military hired us for TRICARE, one of the things that was very important in their purchase decision is, are you going to leave our people battlefield ready? Well, when you look at any large employer, any employer, I think one of the things they count on when they engage us is that their people are going to be better able to help them be the competitive force that they want to be in their own industries. So yeah.
So it almost sounds like you can use all of your employer customers as laboratories where you can learn and identify best practices that you can then bring back and then redeploy with others so that you can actually spread this throughout the market.
It has been the most powerful source of innovation that we've had. The ability to listen with them. And when we do things really well, they're usually elbow to elbow at the table like Target is with us when they do those kinds of things. In fact, we'll go a little further with this notion. Having an employer looking at it gives you something that Samir does, which is that laboratory in which you get to see how people really use this thing, this anthropographic type look at the use of capabilities in this setting and realize whether it's practical, relative, will people use it. But beyond being laboratories for us, our employer relationships are also our professors, because we've learned a lot from dealing with those relationships.
Okay. So I want to go back to this incentive issue. How can an individual physician, if they were to get on board with prevention, have incentives for his practice or her practice to do this, but also have incentives that then translate to the patients that they help manage?
I'll comment on that, and I think Richard may have some thoughts as well. But one of our clients is Sharp Healthcare, and we really work closely with them. And we took 200 of their highest risk patients, put them on our platform. We're seeing great results. And so they're employees. And so Sharp is also, they've got several things called accountable care organizations and they're trying to build products into ACOs. And what ACO is, and you can correct me if I'm wrong, but basically it's a form, it's still fee-for-service medicine, but what it is, it offers now incentives for quality of care and certain outcomes, and you can define which kind of metrics that you can say, whether it's weight or blood pressure or BMI or whatever it is, you can define that. So one of the ways I think that we're looking at really approaching the physician group as opposed to individual physicians is by starting to create ACO models that offer rev up. So for example, we see benefit in this 200 population, we go with 1,000. Then you start seeing benefit there, and then what you can start saying is you start going to UnitedHealth and say, hey, Sharp would like to sell this ACO product, and this ACO product has a wellness platform in it. And this wellness platform has data that if you use it in the proper manner, that you'll drive outcomes. So now it starts from the top, right? So it starts from the financial piece, and then it drifts down from the leadership in the organization. So the leadership in the organization says, hey, if you're a primary care practice and you meet these certain metrics or these parameters, you'll get your incentive rewards, or the ACO will get rewards back. So now the entire system is incentivized to actually use prevention as part of their policy, right? So I think that that's how I see ultimately physicians being reached, through a mechanism somewhere like that as opposed to an individual physician. Because you got to realize, as an individual physician, I'm still being assessed by RVUs. I mean, my administrative manager said, good job, Samir, you saw 125 patients over the last night. It doesn't matter what I did for them. I could have potentially killed 5 of them.
Right.
But if I saw a bunch of RVUs,
Right.
I'm good, right? But so I think we're shifting, and that fabric, that incentive piece for physicians hasn't shifted yet. So it has to shift from the top. The incentives have to start aligning with quality, and it is. Healthcare reform is there. You've got ACO models that are coming up. You have third-party payers that are starting to realize. So it's going to come. It's coming. It's a way of the future,
Right,
and
so
I think that's the way it is.
So that's kind of the physician side. What about the patient side? What sort of incentives, other than, and it doesn't seem like being healthy is a good enough incentive for most people. So are there any other incentives that a physician can provide?
Physician, I think, it's interesting. I really think, again, you're talking about behavior change, right? So what do physicians do? We typically prescribe, right? And we give advice, but let's be honest. I mean, you ask most primary care physicians, which I did, they spend 30 seconds talking about prevention in the last 30 seconds of the visit because they just don't have time. It's not that they don't want to do it, they want to. We want to do more. It's just the system doesn't reward it. So I think what you have to go back to is that the consumer has to have the incentive. So where can they come? Well, we talked about employers. Employers are now saying, listen, we're offering carrots, but we're going to start wielding sticks now. You're going to pay more if your BMI is higher. You're going to pay more if you're obese. You're going to pay more if you're diabetic. And you're going to pay less if you're hitting certain parameters. So 60% of health insurance is today, at least, is given by employers. So employers are now really becoming big purveyors of wellness technologies, and so they are starting to align the incentives with it. So I think, the consumer, the second thing for the consumer to be incentivized by is the fact that I said earlier, is they're paying more for services and products now, right? So, I mean, we all know that premiums are going up, deductibles are going up, copays are going up, employers are paying less for plans than they used to. So I think that there's more of an onus to where now the consumer is saying, maybe I should be interested in prevention and not just going to the doctor.
Yeah, go ahead, Richard.
I think the premise of the question may be something I'm struggling with a little bit. My personal perspective, serving 80 million Americans through relationships with 750,000 physicians, is a physician shouldn't be paying any type of incentive to a patient or offering an incentive. I mean, there are going to be certain things in the relationship where physicians will go out of their way for access for people they have good relationships with, but I think that's passive, and it's not necessarily something that should be structured. I think it is our job as the carrier, the insurer, the carrier, to provide the incentives to the consumer so they pay attention to the physician. And we'll pay the physician based on quality and not based on RVU, so that they're get the physicians and the patients both interested in achieving the same metric. And we can do that because all 82 billion electronic transactions we perform a year get captured into one single database, and we use that to feed to the consumer so they know what they need to be doing, and to their specific physician, so when that patient shows up, one of the two of them is going to talk about it. And then we also report back to the employer or whoever the plan sponsor is, so they can see on a population level whether or not we're doing our job. I really think the burden of incenting the consumer really belongs on the carrier.
Let me open up the floor if there's any questions. I see a hand right there. I see many hands everywhere. So, and the 1, 2, 3, 4th row back on my right side. Yeah, go ahead. Just yell really loud.
So you talked about a lot.
You got a mic? Okay.
You talked a lot about incentives and the like. What I'm trying to get an understanding now is there's a huge way towards defined benefit to defined contribution. And so under the world of defined benefit, you know, it was under the employer's need and the carrier's need to, in fact, have that. Now you're pushing it to defined contribution, and it's back onto the consumer. So how do you think about that?
Great question. So let's talk about what really defined contribution is. There's probably nowhere in American healthcare where this is truly defined contribution. Because, you know, I guess the closest thing to it is when you have an exchange and somebody gets an insurance product, and for the employer, for that single year, the contribution is going to reflect that price. The following year, based on the experience of that group, that premium is going to change. And you notice I'm not pointing downward, right? So what's going to happen is that you get to that point where you're just buying insurance on that basis. Let's go a little broader than that. The real area is in the component of the cost share at the time of service, and that's where you see the broader deductibles. We very much support that, because that increased deductible, and thank heavens the law does still encourage that, is that's a place in which you can help people overcome their burdens by giving them more to do their healthcare purchasing if they do their part of the game in terms of prevention. So I think what you're going to see is the stuff about defined contribution. I don't know where that's going to go. I think the broader thing is going to be higher deductible plans up to a specific level with an ability to help people close that deductible through the incentive program. We have some 40 clients doing it, now serving over 6 million lives. So I think that wave's catching on.
There was another question right there in the front row. Go ahead.
Dr. Migliori, with the high rate of change between insurance plans, between different companies, and the move to Medicare at age 65, what collaborative efforts are being made to reward prevention financially for insurance companies?
Prevention, it's a great question. Prevention is its own reward. Why? Well, when you prevent, if you're able to prevent progression of disease or its onset, you're going to see a happier plan sponsor who's hired you, whether it is whether it's an employer, an individual that's buying it from you, or the government, either at the state or the federal level. As soon as you start showing that you're taking some of that, you're taking a population and getting them more engaged in whatever they're doing, everybody's happy. The second thing is it takes demand out of the system. And when it takes demand out of the system, that's when you start building up your capability of reducing healthcare costs, because that's what really has to be bent. But we don't stop there. The second thing that really needs to be done is that people will need to use the healthcare system at some point, even as for the preventive stuff. What you want to do is provide tools of transparency, so that way people will access the healthcare system at the right time, at the right place, and use the best parts of it. That drives competition within the physician and hospital community. The final thing you want to do is to take that same information and put it in the hands of the physicians and docs, so when those people show up, the docs and the hospitals are at the top of their game, because they're fully informed as to whether or not these people are complying with the doc's orders when they leave the office, either because they can or they won't.
We have time for just one last question, and I've biased the center section because I could see it better, but I'll go to the right side this time. And the woman right in the second row, go ahead.
Thank you. And there's a major shift right now where the payers used to focus on the employers and sell 10,000 populations kits. Now we're going with the exchange where really you have to do retail insurance. And with this higher deductible, do you think that you may have to sell this differently to the consumer themselves as opposed to the employers? Because as you see, the Target, the Walgreens, all these people are moving with the vouchers. And it's going to be like the 401k. We give you $2,500, the IBMs, all those guys are moving there. In 3-5 years, the majority of your consumers are going to be the consumer themselves instead of the employers. How does that affect how you motivate them?
So let's quick answers across the board. So quick answer, Samir first. How does that impact?
I'll let Richard, because I'm not sure how to answer
All right,
that
so
question.
go.
I'm a transplant surgeon.
Because I'm thinking about how your business changes if I, the consumer, am now the buyer of your services and not the health plan or not the employer.
So the question is how RevUp would be delivered differently? Who
To a
would pay for it?
consumer, directly to a consumer.
Well, it's a subscription-based model, what we
Right.
sell to the consumer directly. I mean, so the consumer would essentially pay, which right now we're waiving that fee, but they would pay anywhere from $10 to $15 per month.
So you're positioned for that world, it sounds like.
We are,
the
yes,
way
we
you
are, yes.
So
yes,
go ahead,
yes.
Richard.
The short answer to the question is we will see more alignment because then people start recognizing that this thing I have to buy every year has a certain cost on it. If I can do things to mitigate that cost because of the way I behave, the way I make decisions, and the physicians I choose to see, then they're going to understand at some point that through real transparency that I'm going to mitigate my own costs.
So Marco, would you be concerned in a world where the consumer's got to buy all their stuff themselves out of pocket versus being reimbursed by somebody else?
I would love it. Having great products that are beautiful, easy to use, and convenient, and help the user to have this product work around their lives rather than the other way around. So in a consumer-centric world, that's what the perfect world is like for Qardio and for our products.
Well, thank you very much. Everyone give the
Thank
panelists
you.
a hand.